So again, I'm going to try to make the case that patients with high-risk myeloma should be treated differently. I don't know exactly how they should be treated differently. That's a different issue, but they should be. And briefly, of course, there are a number of ways that you can try to identify which of your myeloma patients have high-risk disease. One that's now currently available commercially, and you can do this on your patients, is to do gene expression profiling. And it has some added benefit on top of FISH analysis, and of course was made quite famous and popular by the folks at Arkansas, and they were able to identify a 70 gene and then later some smaller gene panels that were used to determine patients who were high risk. And you can see from the curves at the bottom of the panel that in fact the outcomes for the standard risk people, which were in green, were quite better than the outcomes for the high risk people in red. And this also was a profile that was useful at the time of relapse, not just in newly diagnosed patients. If you were high risk at the beginning, you stayed high risk. If you were standard risk, sometimes you converted to high risk. And if you did that, then unfortunately your outcome was worsened. These are the 70 genes that were in that model, many of which were on chromosome 1. We still don't know everything about the biology of all of these genes and how they contribute to high risk, but at least it's something to start with. There are other risk profiles that have been produced from gene expression data. There's the European panel, which was a 92 gene panel, which was apparently at least somewhat better perhaps than the 70 gene panel. But again, you can see a big difference between standard risk and high risk. And although there were a couple of genes overlapping between them, actually there were more differences between the panels than similarities. That always gets me a little bit concerned, because you would think that if there are certain genes that contribute to high risk, they should be picked up in all of these, but there is more that we need to learn clearly. And we don't really know which of these is best for sure, but at least the 70 gene model is the one that you can get on your patients. So I would encourage you to do that. More recently, there are also profiles of smaller gene panels, which may make it a little bit cheaper to do in the future. This is a 17 gene panel that seemed to predict outcomes after transplant. And there may have been, again, some comparative studies suggesting that one may be a little bit better than another, although we're not yet to the point where we can really, I think, pick a winner. There are also other indices that have been reported over the years. Here's one that I picked out that looked at something called the Centrosome Index, which seemed to say that if you had lots of cell cycle genes expressed, essentially, then you were more aggressive, which makes sense, at least biologically, because if the cells are going to grow more rapidly, they're going to be more aggressive. Of course, FISH is something you're very used to using, and here are some data with deletion 17p, which is one of the bad actors and probably one of the more common ones. At least about 10% at the time of diagnosis will have deletion 17p by FISH, but in the relapsed refractory setting, you're probably talking about maybe 30%, maybe even 40%. So think about redoing the FISH if people relapse, especially after transplant. Now, this is where some of the data about should patients be treated differently get kind of interesting, because you saw briefly mention of this study before, and I wanted to take a little bit of a deeper dive here. So this was a Dutch and German study. There were two arms here. One arm got a thalidomide-based induction. Actually, they got VAD, which was vincristine, doxorubicin, and dex, then tandem transplant, and then thalidomide as a maintenance. And the second group got bortezomib, doxorubicin, and dex induction, tandem transplant, and bortezomib as a maintenance. And if you look at the curves, the interesting thing is that the standard risk group patients actually did roughly the same, whether they got the bortezomib induction, transplant, and maintenance, or the old induction, transplant, and maintenance. The main difference, the only reason the study was positive, was because the deletion 17p patients did substantially better with bortezomib upfront and after transplant. So that isn't necessarily the biggest sample size here, but it does make the case that really perhaps they should be treated differently. And this has been true in terms of high-risk patients in other studies showing that generally their outcome is better if they have novel agent-based therapies, including proteasome inhibitors, and probably more likely lenalidomide, not so much thalidomide. And there's a little bit of data about pomalidomide as well. And just to show you that even great combos like KRD that you heard quite a bit about still don't completely overcome high-risk disease. Here is a little bit of a deeper dive at the ASPIRE data. You've seen this before, but if you look at the efficacy analysis here by risk status, and this was presented at this past year's ASH, you can see that there is improvement if you get KRD versus RD, whether you have standard risk or whether you have high risk. But high risk still doesn't do the same as does standard risk. So there's still something there that we need to do better with. And it may be, as you heard from Ruben earlier, that monoclonal antibodies will be the ticket because maybe they won't care what's inside the cell as long as it expresses the target on the surface of the cell, although I don't think we have enough data yet to be sure about that. And then you also saw some of the Endeavor data, which was KD versus VD. And once again here, there was evidence that still high-risk patients don't do as well as standard risk patients, even with proteasome inhibitors, which we think are part of the solution, at least, to high-risk disease. And here's some updated efficacy data, which again show you that, unfortunately, the high-risk patients, even with our current best therapies, don't do quite as well. So just for your own reference, this is one of the consensus definitions for what is high risk, which is used in the SWOG study, which currently is RVD plus minus ELO. And the next version, which is going to open later this year, is KRD plus minus DARA. The definition is high risk by any of the GEP models that are out there, although the 70 gene is what you can do commercially. If you have primary plasma cell leukemia, if you have LDH that's at least twice the upper limit of normal, or if you have any one of those FISH abnormalities, most commonly it's going to be deletion 17p or 1q21 amplification. The others are relatively uncommon. And this is the IMWG definition, which just recently got published in an overview paper on high-risk disease. It's available online on Blood and does provide some general guidelines. And they also consider karyotypic loss of chromosome 13 to be high risk, as well as some other abnormalities. So here's a little bit of an overview to summarize the data. There is high-risk disease at every stage in the myeloma spectrum. You can see MGUS patients who, if they're at low risk, which is at the top, you can see they have a very low risk of progression. But there is high-risk MGUS, which has a much greater possibility of progression. For smoldering myeloma, median time to progression may be 9 years if you're low risk, but only 2 to 3 years if you're high risk. For symptomatic myeloma, great survival now at 2+ years, not so great if you're at high risk, and especially in the relapsed refractory setting, the numbers are really quite poor. So unfortunately, high-risk disease is out there, you see it, and this is probably what patients die of. If you have good risk myeloma, you probably don't die. So those are the conclusions I'd leave you with. There's definitely high-risk disease. It has a bad PFS and OS. We think that maybe bortezomib and lenalidomide will help reduce the impact of deletion 17p and 414. Some people believe in tandem transplant, although we don't have enough randomized data. One thing we do at MD Anderson is we're adding natural killer cells that are infused after transplant to help bring an additional immune reaction. So I think, again, my conclusion is there is high-risk disease. We don't know for sure how best to treat it, but probably more novel agents before transplant, and novel agent combination-based maintenance is the right way to go. And I'll turn it over to Ruben to see what he has to say. And I do think in the future that immunotherapy will have an important role to play here, and maybe something like a CAR T-cell after a transplant to get down to even lower levels of minimal residual disease. Thanks very much.